Hello everyone, and welcome back to another chapter of Advanced Pharmacology. Today we're discussing Unit 12, Men's Health, and specifically we'll jump on to Chapter 50, Androgens. So, androgens. Androgens are hormones that are produced by the testes, ovaries, and adrenal cortex. The major endogenous androgen is testosterone. Androgens are noted most for their ability to promote expression of male sex characteristics. However, androgens also influence sexuality in females. In addition, androgens have significant physiologic and pharmacologic effects unrelated to sexual expression or function. The primary clinical application of the androgens is management of androgen deficiency in males. Principal adverse effects are viralization and hepatotoxicity. So, talking specifically on testosterone. Testosterone is the prototype of the androgen hormones. This compound is principal endogenous androgens in both males and females. In addition to its physiologic role, testosterone is representative of the androgens employed clinically. Its biosynthesis and secretion, therefore, in males, testosterone is made by the Leydig cells of the testes. Daily production in men ranges from 2.5 to 10 milligrams. Synthesis is promoted by two hormones of the anterior pituitary, the follicle-stimulating hormone, or FSH, and luteinizing hormone, or also known as LH, also known as the interstitial cell stimulating hormone. Production of the testosterone is regulated by a negative feedback control. Rising plasma levels of testosterone act on the pituitary to suppress further release of FSH and LH, thereby decreasing the stimulus for further testosterone formation. Some of the testosterone present in plasma is produced by the adrenal glands. However, androgenic activity of adrenal origin is much less than that of testicular origin. Therefore, in males, adrenal androgens have minimal functional significance. Testosterone production changes over time. Peak production occurs around the age of 17. Production then remains steady until the age of 30 to 40, after which it slowly starts to decline. By the time a man reaches 80 years, testosterone production is only half of what it was in his youth. In females, preandrogens, the precursors of testosterone, are secreted by the adrenal cortex and their ovaries. Conversion into testosterone takes place in the peripheral tissue. Synthesis of preandrogens by the adrenal glands is regulated by the adrenocorticotropic hormone, whereas synthesis of the preandrogens by the ovaries is regulated by the luteinizing hormone. Daily testosterone production is only about 300 micrograms. The total is 10 to 40 times less than the amount produced in men. In the event of an ovarian or adrenocortical pathology, secretion of androgens can increase greatly and may be sufficient to produce viralization. At menopause, testosterone production decreases. So how does it work? Well, the mechanism of action, the effects on testosterone, or better yet on its target tissues, are mediated by specific receptors located in the cell cytoplasm. After binding of testosterone to its receptors, the hormone receptor complex migrates to the cell nucleus and then acts on DNA to promote the synthesis of specific messenger RNA molecules. These in turn serve as a template for the production of specific proteins, which then mediate testosterone effects. It should be noted that in some tissues, prostate, seminal vesicles, and hair follicles, androgen receptors do not interact with testosterone itself. Rather, they interact with the dihydrotestosterone, a testosterone metabolite. So what is its physiologic and pharmacologic effects? The effects on sex characteristics in males. Pubertal transformation. Increased production of testosterone promotes the transformation that signals puberty in males. Under the influence of testosterone, the testes enlarge, after which the penis and scrotum enlarge. Pubic and axillary hair appears, and Hair on the trunks, arms, legs assumes adult male pattern. Testosterone stimulates the growth of bone and skeletal muscle, causing height and weight to increase rapidly. Testosterone also accelerates epiphyseal closure, causing bone growth to cease within a few years. The larynx enlarges, thereby deepening the voice. Sebaceous glands increase in number, causing the skin to become oily. Acne results if the glands become clogged and infected. The final pubertal change is the beard development. Several years are required for all of these changes to occur. Spermatogenesis. Androgens are necessary for the production of sperm by the seminiferous tubules and for maturation of sperm as they pass through the epididymis and the vas deferens. Androgen deficiency can cause sterility. So, its effects on sex characteristics, therefore, on females. Under physiologic conditions, the endogenous androgens have only moderate effect in females. The principal among these are the promotion of the clitoral growth and perhaps the maintenance of normal libido. However, when the production of androgens becomes excessive, viralization can take place. Viralization can also occur in response to therapeutic use of androgens or to androgen abuse. Its anabolic effects. Testosterone promotes growth of skeletal muscle. This anabolic effect results from binding of androgens to the same type of receptor that mediates androgen actions in other tissues. Effects in young males and in females of any age can be dramatic. In contrast, effects in the healthy adult male are modest. The testes of adult males already produce enough testosterone to cause near maximal stimulation of the musculature, so in adult males, the increment in muscle mass that can be achieved with exogenous androgens is actually relatively small. Erythropoietic effects. Testosterone promotes the synthesis of erythropoietin, a hormone that acts on bone marrow to increase the production of erythrocytes. This action of testosterone, together with the high levels of testosterone present in males, explain why men have a higher hematocrit than women. When women are giving testosterone, the hematocrit rises and hemoglobin levels increase by an average of 4.3 grams per deciliter. In contrast, because men have high testosterone levels to begin with, the increase in plasma hemoglobin that can be elicited with exogenous androgens is smaller, only about 1 gram per deciliter. So, the clinical pharmacology of androgens. In addition to testosterone, a few other androgens are employed clinically. All of these agents can bind to androgen receptors and therefore can all elicit a similar response. Major differences among individual androgens pertain to the route of administration, its pharmacokinetics, adverse effects, and specific applications. So, we'll speak on a couple different classifications, therefore. The androgens used clinically fall into two basic groups, testosterone and testosterone esterases, and the 2,17-alpha alkylating compounds. Androgens belong to each group are shown in the following table, 50.1. So here's a good spot to hit pause so you can see the difference between the testosterone/testosterone esters versus the 17-alpha alkylated androgens. When speaking of testosterone-like compounds, it is traditional to distinguish between androgens and anabolic steroids. However, we will not make this distinction because it is now clear that the receptor site that mediates the androgenic actions of the androgens is the same receptor site that mediates the anabolic actions of the hormone. Consequently, it has not been possible to separate anabolic activity from androgenic activity. Virtually all anabolic hormones are also androgenic. Accordingly, rather than creating two categories, androgens versus anabolic steroids, and assigning some agents to one category and some to the other, we will refer to all of these testosterone-like drugs as androgens. So, the therapeutic use. In April of 2015, the FDA published a required label that a label change for testosterone. The new label approves testosterone use only for patients who have confirmed testosterone deficiency due to hypogonadism. The FDA further emphasized that lowering testosterone due to aging did not meet criteria for hypogonadism. The Endocrine Society has published their clinical guidelines for managing testosterone therapy, and their algorithm to guide diagnosis of low testosterone due to hypogonadism is included in the article. So there is an article by the press. Um, Make sure you hit pause and take a look at it. Individual androgens differ in their applications. No single androgen is employed for all of the uses discussed here. Specific applications of individual androgens are again shown in Table 50.1. So, male hypogonadism. When a man has hypogonadism, the testes fail to produce adequate amounts of testosterone, so replacement therapy is required. Male hypogonadism may be hereditary, or it can result from other causes, including pituitary failure, hypothalamic failure, and primary dysfunction of the testes. When complete hypogonadism occurs in boys, puberty cannot take place unless exogenous androgens are supplied. To induce puberty, a long-acting parenteral preparation is chosen. Under the influence of these androgens, the normal sequence of pubertal changes begins. Growth is accelerated, the penis enlarges, the voice deepens, and other secondary sex characteristics start to become expressed. As in normal males, these changes take place over several years. So, it's replacement therapy, therefore. Androgens replace therapy is beneficial when testicular failure occurs in an adult male. Some studies demonstrated that the treatment restores libido, increases ejaculate volume, and supports expression of secondary sex characteristics. However, treatment will not restore fertility. The principal drugs employed for testosterone replacement are testosterone itself and two testosterone esters, testosterone enanthate and testosterone cypionate. Preparations and dosages for replacement therapy are shown here in the following table. And this is an excellent spot to hit pause so you can see all the different formulations, the drugs, the dosage, where it sits in our CSA schedule, as well as some additional comments. And I'm pretty certain we'll discuss each of these coming up. So, first we'll speak though further on delayed puberty. In some boys, puberty fails to occur at the usual age, meaning before the age of 15. Most often, this failure reflects a familial pattern of delayed puberty and does not indicate any type of pathology. Puberty can be expected to occur spontaneously, but later than usual. Therefore, although androgens therapy can be employed, treatment is not an absolute necessity. However, the physiological pressures of delayed sexual maturation are sometimes greater than a boy can tolerate. In those cases, a limited course of androgen therapy may be indicated. Both fluoxymesterone and methyltestosterone are approved for that purpose. If delayed puberty is the result of true hypogonadism, long-term replacement therapy is indicated. Replacement therapy in the menopausal woman. Testosterone, again, is decreased during menopause, so testosterone replacement therapy can alleviate some of the menopausal symptoms, especially fatigue, reduced libido, and reduced genital sensitivity. Testosterone is not approved for replacement in women in the United States, although it has been approved in the United Kingdom. Treatment of transsexualism. Testosterone is used to masculinize therapy for patients who are born with a female body but self-identify as a male. Anticipated effects are increased hair growth over the face and body, a deepening of the voice, breast tissue atrophy, and cessation of menses. An increase in muscle tissue relative to adipose tissue also occurs. Therapy is highly individualized by specialists in the transgender health. Cachexia. Cachexia is a wasting of the body associated with severe illness, which does include AIDS, severe trauma, and chronic systemic infections. Testosterone levels often decline in these patients, putting them at risk for wasting and loss of muscle mass. Testosterone therapy can decrease that risk. Oxandrolone, or Oxedrin, is FDA approved for just that purpose. Oxandrin is an anabolic steroid that is synthetic derivative of testosterone. However, it does have a black box warning, in which it can cause Paleosis hepatitis, a condition in which blood-filled cysts form in the liver, leading to liver failure and intra-abdominal hemorrhage. It can also contribute to the development of highly vascular liver tumors. An increased risk for atherosclerosis can occur secondary due to marked elevations in LDL and a decrease in HDL. Anemias. Androgens are sometimes used in men and women to help treat anemias that have been refractory to other therapies. Anemias most likely to respond include aplastic anemia, anemia associated with renal failure, Fanconi anemia, and anemia caused by cancer chemotherapy. Androgens help relieve anemia by promoting the synthesis of erythropoietin, the renal hormone that stimulates the production of red blood cells and possibly white blood cells, as well as platelets. With the emergence of other therapies, such as erythropoietin-stimulating agents, however, androgens have fallen out of favor for off-label treatment for anemia. Which brings us to our adverse effects. There is a spot here to pause on androgens in regards to their patient-centered care across the lifespan. So make sure you take a look at that. So next, we'll talk about the viralization in women, girls, and boys. Viralization is the most common complication of androgen therapy. When taken in a high dose by a woman, androgens can cause acne, deepening of the voice, proliferation of facial and body hair, male pattern baldness, increased libido, clitoral enlargement, and menstrual irregularities. Clitoral growth, hair loss, and lowering of the voice may be irreversible. Masculinization can also occur in children. Boys may experience growth of pubic hair, penile enlargement, increased frequency of erections, and even priapism. In girls, growth of pubic hair and clitoral enlargement may also occur. To prevent irreversible masculinization, androgens must be discontinued when viralization effects first start to appear. Premature epiphyseal closure. When given to children, androgens can accelerate epiphyseal closure, thereby decreasing adult height. To evaluate androgen effects on the epiphysis, radiographic exams of the hand and wrist should be performed every 6 months. Hepatotoxicity. Androgens can cause cholestatic hepatitis and other disorders of the liver. Clinical jaundice may occur but is considered rare. Patients who are receiving androgens should undergo periodic tests of liver function. If jaundice starts to develop, it will reverse after discontinuation of androgen use. Androgens may also be carcinogenic. Hepatocellular carcinoma has developed in some patients after a prolonged use of these drugs. It must be emphasized that not all androgens are hepatotoxic. Liver damage is associated primarily with the 17-alpha alkylated androgens. These androgens all share a structural feature that is in common, an alkyl group substituted on carbon 17 of the steroid nucleus. Because of their capacity to cause liver damage, the 17-alpha alkylated compounds should not be used long term. In contrast to the 17-alpha alkylating androgens, testosterone and testosterone esters are not associated with any liver disease. Effects on cholesterol level. Androgens can lower plasma levels of the highly density lipoprotein cholesterol, or the highly desired cholesterol, and elevate plasma levels of the low density lipoprotein, or less desired cholesterol. These actions may increase the risk for atherosclerosis and related cardiovascular events. Prostate cancer. Androgens do not cause prostate cancer, but they can promote the growth of a cancer after it has already occurred. Accordingly, androgens are contraindicated for men who are diagnosed with prostate cancer. Men without diagnosed prostate cancer should be monitored for emergence of covert cancer. Edema. Edema can result from androgen-induced retention of salt in water. This complication is a concern for a patient with heart failure and for those with a predisposition of developing edema from other causes. Treatment consists of discontinuing the androgen and giving a diuretic if needed. Abuse potential. Again, as this will be discussed a little bit later, but androgens are frequently misused or abused to enhance athletic performance. Because of their abuse potential, nearly all androgens are regulated as a Schedule III controlled substance. The risk for thromboembolic events. There have been post-marketing reports of thromboembolic events, including a stroke, MI, DVT, and PEs. These events are believed to be the result of testosterone erythropoietic effects. While long-term clinical trials are not available and randomized controlled trials have been inconclusive, the concern was sufficient to prompt the FDA to issue a testosterone product safety alert in 2014 to address the potential life-threatening concerns. Androgen preparations for male hypogonadism. So, treatment options for androgen replacement therapy have expanded in the recent years. In the past, an IM therapy with a long-acting testosterone ester was the major treatment mode. Today, we have six attractive alternatives: a nasal gel, a transdermal patch, a transdermal gel, a topical solution, a buccal tablet, and an implantable subcutaneous pellet. All these formulations are regulated again as a Schedule III controlled substance. So, talking on our oral androgens. Only two androgens are approved for oral therapy of male hypogonadism. Both drugs, fluoxymesterone and methyltestosterone, are 17-alpha alkylated androgens and therefore pose a risk for hepatotoxicity. Accordingly, they should not be used long-term and are not first-line agents. The transdermal testosterone. Testosterone is available in three transdermal formulas: a patch, gel, and liquid. With all three formulations, testosterone is absorbed through the skin and then slowly absorbed into the blood. So, speaking strictly on the patch, testosterone patches, also known as androderm, is indicated for male hypogonadism. Two strengths are available, 2 and 4 milligrams of testosterone in 24 hours. They are applied daily to the upper arm, thigh, back, or abdomen. The principal adverse effect is usually a rash at the site of application, so it's important that you rotate that site. Gels. Gels have actually a black box warning here. Testosterone gel and topical solution. Secondary exposure to testosterone gel on uncovered skin and to testosterone gel on unwashed clothing has resulted in viralization in children. So, testosterone is available in 4 gel formulas, sold as Androgel, Testum, Fortesta, and Vogel Exo. Androgel contains 1% or 1.62% testosterone. Testum contains 1% testosterone and Fortesta contains 2%. Vogel XO is available in both unit dose tubes and multi-dose metered pumps. Each unit dose tube provides 50 mg testosterone. Each actuation of the pump provides about 12.5 milligrams of testosterone. Again, all 4 gels are applied once daily to treat male hypogonadism. After the gel is applied, testosterone is absorbed rapidly into the skin and then slowly into the blood over the next 24 hours. When compared with a transdermal patch, the gels have 3 advantages. They cause less local irritation, they can't fall off, and they produce more consistent testosterone levels. The principal disadvantage of the gel is that testosterone can be transferred to others by skin-to-skin contact. This is possible because only 10% of an applied dose is absorbed. The other 90% remain on the skin after the gel dries. In one study, blood levels of testosterone was doubled in female partners of gel users after 15 minutes of intimate contact that occurred 2 to 12 hours after the gel had been applied. Testosterone transfer is a concern because the drug can cause viralization of female partners and can also cause fetal harm. In children, contact transfer can cause genital enlargement, premature development of pubic hair, advanced bone age, increased libido, and aggressive behavior. In most cases, these effects regress after testosterone exposure stops. To reduce the risk of unintended gel transfer, there is a guideline to follow. The gel users need to wash their hands with soap and water after each application. Gel users need to cover the application site with clothing once the gel has dried. Gel users need to wash the application site before skin-to-skin contact with another person. Women and children should avoid skin-to-skin contact with application sites on the gel user. And women and children who make accidental contact with the gel application site should wash their contaminated skin immediately. So, androgen gel is supplied in a metered dose pump and it delivers a 12.25 milligram per actuation, so 1%, or 20.25 milligrams per actuation, which would be the 1.62%, in unit dose foil packets containing 20.25 milligrams of testosterone and 40.5 milligrams of testosterone. The gel is applied once daily to clean, dry skin of the shoulders, upper arms, or abdomen, but not the genitalia. Instruct patients to not squeeze the entire contents of the packet into the palm and then immediately apply the gel to the skin and rub it in. To prevent the transfer of testosterone to others, patients should wash their hands and, after the gel has dried, keep the treated area covered with clothing. Because testosterone can be washed off, patients should wait 5 to 6 hours before showering or swimming. To ensure safe and effective dosing, blood levels of testosterone should be measured 14 days after initiating therapy and periodically thereafter. Testum is available in a 5-gram tube that contains 50 milligrams of testosterone, of which 10% gets absorbed. It is applied once daily to the skin of the shoulders or upper arms, but not to the abdomen or scrotum. As with androgel, patients should wash their hands immediately and keep the treated area covered. They should also avoid showering for at least 2 hours. Testosterone levels should be checked after 14 days and periodically thereafter. Fortesta is supplied in a metered dose pump that delivers 10 milligrams of testosterone per actuation. All doses are applied to the front or inner thigh. As with androgels, patients should wash their hands immediately and keep the treated area covered. Also, they should avoid swimming or showering for at least 2 hours. Fortesta is a flammable, alcohol-based formula, and therefore patients should avoid flames or smoking until the gel has dried. Testosterone levels should be checked after 14 and 35, and after 14 days, and then again after 35 days, and periodically thereafter. Vogel XO is a tube formulation which is applied in the same manner as Testum. Again, it's a metered dose pump that is applied, and it has the same advice and precautions. So that brings us now to our topical solutions. Testosterone topical solution for underarm application, which is our Axe Iron, is much like the testosterone gels. The principal difference is the application site. Axe Iron liquid is formulated specifically for the application to the axilla, whereas Testum is applied to the shoulder or the upper arm. And Androgel is applied to the shoulder, upper arm, or abdomen. After its application, testosterone is rapidly absorbed into the skin and then slowly into the blood. A steady state level is usually reached within 14 days. After the application stops, blood levels can take between 7 to 10 days to decline to baseline. Axe Iron is supplied as an alcohol-based solution in a metered dose pump that delivers 30 milligrams of testosterone per actuation. Dosing is done by pumping the liquid onto an applicator and then applying the liquid to clean, dry, intact skin of the underarm, and not to any place else. Patients should not swim or bathe for 2 hours after application, and if an underarm deodorant or antiperspirant is used, it should be applied before applying testosterone. Because of its alcohol content, Axe iron liquid is flammable. Accordingly, users need to stay away from flames until the solution has dried. Axe iron is applied to each axilla at the same time every morning, and after 14 days or longer, blood levels of testosterone are measured, and dosage is then adjusted whether up or down, depending on the lab. Like the testosterone gels, testosterone topical solution can be transferred to others through skin-to-skin contact, posing again a risk to women and children. Accordingly, the same guidelines noted previously should be followed. That is, X-iron users should wash their hands after every application, cover the application site with clothing after the solution has dried, and wash the application site before anticipated skin-to-skin contact with another person. Women and children should avoid contact with skin where X-iron was applied and should wash contaminated skin if accidental contact with an application site has occurred. The nasal gel. Testosterone nasal gel is the newest formula approved for testosterone administration. It comes in a metered dose pump and sprays 5.5 milligrams of testosterone each time the pump is actuated. Because the drug is administered nasally, patients with nasal disorders or abnormalities should not take this medication. There has not been adequate testing for interactions with other nasally administered drugs. Currently, only adrenergic agonists are approved for the administration of Natesto. The route of administration can cause localized reactions, and these include rhinorrhea, epistaxis, and nasopharyngitis. However, these tend to be modest effects at best. So, how the administrations are supplied with a drug, however, it is important that the provider be aware of these in order to answer patient questions. The pump should be primed before the use, and excess gel needs to be removed. The patient should blow the nose before administration. The pump is inserted into the nostril with the tip aimed towards the lateral nostril wall. The pump is depressed slowly until it stops. As the tip is withdrawn, it should be wiped against the lateral nostril wall to ensure that the remaining gel is distributed to the nostril. After administration in both nostrils, the nose should be lightly massaged below the nasal bridge. And finally, patients should avoid blowing or sniffing for at least 1 hour after its administration. Which brings us to the implantable testosterone pellets. Testosterone pellets, or Testopel, are long-acting formulas indicated for male hypogonadism and delayed puberty. The pellets are implanted subdermally in the hip area or abdominal wall lateral to the umbilicus. Each pellet contains about 75 milligrams of testosterone, and the usual dosage is anywhere between 150 to 450 milligrams every 3 to 6 months. About 1/3 of the dose is absorbed in the first month, 1/4 of the second month, and 1/6 third month. For patients switching from an IM testosterone propionate or IM testosterone enanthelate, the recommended dosage is 2 pellets for each 25 milligrams of IM testosterone used weekly. So, for example, a patient who is receiving 75 milligrams of IM testosterone enanthelate each week should switch to 6 pellets every 3 to 4 months. The buccal tablets. Testosterone buccal tablets, also known as Striant, is approved again for male hypogonadism. It produces a steady blood levels of testosterone, and the tablets are applied to the gum area just above the incisor tooth and are designed to stay in place until they are removed. To ensure good adhesion, tablets should be held in place with a finger over the lip for at least 30 seconds. The recommended dose is 1 tablet every 12 hours, alternating sides of the mouth with each dose. If a tablet falls out before 8 hours, it should be replaced with a new one for the remainder of the dosing interval. If the tablet falls out after 8 hours, it should be replaced with a new one, and the next scheduled dose should be skipped. The tablets are not affected by eating, drinking, chewing gum, or brushing teeth. Adverse effects, which are usually transient, include local irritation, a bitter taste, and taste distortion. Treatment up to 1 year has not caused any kind of gum changes. It has been hypothesized that the transfer of testosterone from buccal routes may occur through saliva transfer during kissing. Your intramuscular testosterone esterases. There's two IM testosterone esters that are available. Again, testosterone cypionate and testosterone enanthate. Both drugs are formulated in oil and both are long-acting. After an IM injection, these drugs are slowly absorbed and then hydrolyzed to release free testosterone. Unfortunately, these preparations produce testosterone blood levels that vary widely. Testosterone levels are higher than normal immediately after dosing and decline to lower than normal before the next dose. So as a result, patients may experience significant variations in libido, energy, and mood. So that brings us now to our androgen abuse by athletes, which are our anabolic steroids. Many athletes take androgens and androgen precursors to enhance athletic performance. The potential benefits of this practice, although substantial, are accompanied by significant risk. Drugs commonly used by athletes during nandrolone, stanozolone, and methanolone. All these drugs are regulated as controlled substances, making their use without a prescription illegal. So who takes steroids? Well, steroid use is especially prevalent among baseball players, football players, weightlifters, discus throwers, shot putters, and bodybuilders. These drugs are also used by sprinters and athletes in endurance sports. Steroids are used by athletes of all ages, and this includes professionals as well as athletes in college, high school, and junior high. Use is not limited to males. Some females also take them, despite masculinizing effects. So, what can anabolic steroids do for the athlete? Well, exogenous androgens can significantly increase muscle mass and strength in males and females of all ages when given in sufficient large doses. After 10 weeks, one study showed that testosterone treatment produced a 7-pound increase in muscle mass in subjects who did not exercise, and a 13-pound increase in subjects who exercised and took the drug. In contrast, exercise in the absence of exogenous testosterone produced only a 4-pound increase in muscle mass. Similar increases were shown in the subject's ability to bench press weights. However, the potential for adverse effects of androgens is substantial. Salt and water retention can lead to hypertension. When administered in high doses, which are used by athletes, androgens suppress the luteinizing hormone and follicle-stimulating hormone, resulting in testicular shrinkage, sterility, and gynecomastia. Acne was usually common. The reduction of HDL cholesterol and the elevation of LDL cholesterol may theoretically accelerate the development of atherosclerosis. Because most of the androgens that athletes take are 17-alpha alkylating compounds, hepatotoxicity is an ever-present risk. Most recently, androgens have been linked with kidney damage. In females, androgens can cause menstrual irregularities and viralization. Baldness, growth of facial hair, and voice changes may again be irreversible. In boys and girls, androgens promote premature epiphyseal closure, reducing attainable adult height. In boys, androgens can induce premature puberty. What about physiological effects? Androgens are reputed to cause depression, manic episodes, and aggressiveness. There have been very few controlled studies to measure physiologic effects of androgens. However, in the controlled studies undertaken, dosages of androgens were less than those typically taken by an athlete. Surveys of athletes who engaged in the anabolic steroid use indicate an association with risky behavior and aggression. However, it is possible that these were inherited traits of the surveyed athletes regardless of steroid use. Long-term androgen use can lead to an abuse syndrome. Characteristics include preoccupational with androgen use and a difficulty in stopping use. When androgens finally are discontinued, an abstinence syndromes can develop similar to that produced by withdrawal of alcohol, opioids, and cocaine. So, because of their abuse potential, the anabolic steroids are classified as a Schedule III substance, under an amendment to the Controlled Substance Act. For more information on drug abuse in sports, a good place to start is the www.vada-ama.org, a website that is for the World Anti-Doping Agency. This organization is dedicated to promoting, coordinating, and monitoring the fight against the use of anabolic steroids and other banned substances in sports. Other good resources include the U.S. Anti-Doping Agency and the National Center for Drug-Free Sports. Which brings us finally to the prescribing and monitoring considerations. So, the pre-administration assessment, its therapeutic goals in males, well, the treatment of hypogonadism is the only FDA-approved use of an androgen. So, by identifying our high-risk patients, androgens again are contraindicated for the pregnant woman, for men who have prostate cancer or breast cancer, or for someone who's trying to enhance their athletic performance. There are administration considerations. Again, advise patients to take oral androgens with food if there is any kind of GI upset. The transdermal gel in solution. Again, it's important to advise patients to wash their hands after applying the gel and to cover the site of application with clothing. Instruct patients not to shower or swim for several hours. Warn users of the topical solution to avoid being near flames until the liquid has fully evaporated. And buccal. Instruct patients to apply buccal tablets to the gum just above the upper incisor tooth and to apply pressure to ensure good adhesion. The implantable pellets. Again, pellets are implanted subdermally in the hip region or in the abdominal wall, lateral to the umbilicus. Nasal. Instruct patients to blow the nose before using or applying the lateral nostril wall of both nares. Massage the nose after administration and to avoid sniffing or blowing for at least 1 hour. Other ongoing monitoring and intervention. Again, minimizing the adverse effects, especially viralization. Because viralization may occur in women, girls, and boys, assess for deepening voice, chest and facial hair, acne, and menstrual irregularities at each clinical encounter. Irreversible changes may be avoided if the androgens are withdrawn early. Again, premature epiphyseal closure. Accelerated bone maturation in children can decrease attainable adult height. Monitor effects on the epiphysis with radiographs of the hand and wrist at least twice yearly. Hepatotoxicity. Again, this is strictly with the 17-alpha alkylated androgens, which can cause cholestatic hepatitis, jaundice, and other liver disorders. Rarely liver cancer develops. You want to monitor for signs and symptoms of liver dysfunction, such as jaundice, fatigue, and malaise. Obtain your periodic tests of liver function. Liver function normalizes after the cessation of drug use. Avoid long-term use of 17-alpha alkylated preparations. Edema. Salt and water retention may result in edema. Again, assess for edema and weight gain at each clinical encounter. Treatment consists of androgen withdrawal and, if necessary, the use of a diuretic. Teratogenesis. Androgens can cause the masculinization of the female fetus. To rule out pregnancy before androgen use is important. Ensure that female patients of childbearing age are using adequate contraception and are engaging in consistent use. Prostate cancer. Avoid androgens in men with diagnosed prostate cancer. In men without diagnosed prostate cancer, you want to make sure you monitor for exacerbation of pre-existing but covert prostate cancer. And again, injury from skin-to-skin transfer of topical testosterone. Topical testosterone, applied as a gel or topical solution, again can transfer to others through skin-to-skin contact. It's been hypothesized that transfer of testosterone from the buccal route may occur through the saliva transferred during kissing. Transfer of testosterone to women again can cause masculinization as well as fetal harm if the woman is pregnant. Transfer to children can cause genital enlargement, premature development of pubic hair, advanced bone age, increased libido, as well as aggressive behavior. So here's a couple spots to hit pause because there are some other patient education, again, regarding topical testosterone and androgens. So I'll leave that up in one spot, and you can read it all at once. That actually concludes our chapter here for today. So as always, I thank you for listening, and I'll see you all at the next chapter. Till then, thank you, and have a good day.